Hi everyone, welcome to Report Out. Good to see you all. We've got some really good colleagues joining us today for Report Out. On Nasira, not seen you for a while, Nasira, hope you're well. Good to have you on Report Out. And Nasira is going to be reporting on the acute general surgery value stream. And also John, on the great work that's going on in patient experience with the complaint 150-day report out. Time flies, doesn't it? So as usual, what we'll do is have our colleagues report out, and then when both Nasira and John have reported out, we'll open it up for Q&A. So I'd like now to hand over to you, Nasira. Welcome. And looking forward to hearing what you've got to say about the work on acute general surgery value stream.
Thank you very much, Julian. And yeah, it's nice to be back. It's nice to see everyone, albeit virtually. So yes, a familiar platform, but slightly different. But for those who don't know, hello, my name is Nasira. On behalf of my team, I'd like to thank you very much for giving us the opportunity to speak today about our improvement work. And as some of you may know, acute general surgery has this value stream. Next slide, please. Thank you. So just to give you a brief background, LTHT has the busiest acute surgical unit in the UK. The surgical assessment unit was created 7 years ago, and year on year, we've noted an annual 11% increase in patient numbers, and we are seeing on average about 90 patients a day. This equates to approximately a third of the number of patients attending the ED department on the St James's site. We have NELA data, which is a mandated national audit, looking at the number of laparotomies, and shows that we are the highest in number. Next slide, please. And there is just a little sort of pictorial demonstration of the increases that we're seeing, and we're well over the 2,000 mark. Next slide, please. So the challenges that we have for our patients is that this increasing number has led to lengthier waiting times on SAU and delays to a senior review. So not only was SAU receiving first presentations of patients, but also patients returning for imaging and repeat review, thus working as an ambulatory unit within an assessment unit. The on-call surgical consultant was fulfilling multiple roles, including a ward round of all the acute surgical patients, being present in the acute theatres, and this is whilst also trying to review acute admissions. The availability of ultrasounds and CT, so diagnostics, was increasing, and this was limited. This is causing further delay in patient treatment and management. The emergency surgical cases were placed on a shared emergency list and no dedicated biliary list, a gallbladder list, and again, delays in definitive management. So there was a general theme here of delays, and collectively this was recognised as a significant impact on patient and their quality of care. Next slide, please. So for patients, their journey, their satisfaction, their experience, and in turn, that led on to some reduction, I would say, in staff morale. So it was really recognised that this was an area that needed to be explored. Next slide, please. So it was under the guidance of Lindsay Muchavaviri, who was a project lead for Acute, so Mr. Andrew Smith, the lead clinician for Acute, and Yvette Ode leading as the executive lead. Lots of KPO support to providers with this value stream using the LIM methodology to improve this patient journey with the tools that you can see in the RPIWs. It also embarked on a national QI programme looking at the ambulatory, the national ambulatory network. It became fairly evident that the ambulatory emergency care, next slide please, sorry, is a way of managing these patients and a significant proportion of emergency patients without actually needing to be admitted to a hospital bed, and certainly with a timely senior review and decision making. This ambulatory approach has been considered a transformational way of delivering care and has the potential certainly to make emergency care significant as day case surgery is to elective care. And this is the move that LTHT has been making. Next slide, please. So the team, as I mentioned, collectively worked on the drivers for change and how to implement those changes. It's a very busy slide I won't go through, but this is just to give you an example of the work. Next slide. The team embarked on 4 RPIWs, so rapid process improvement workshops, looking at different factors within the patient journey. So 1 inch wide, 1 mile deep, as we say. And in various areas, we looked at patients attending SAU to time of triage and reducing that time from 22 to 9 minutes, improving patient communication with the development of a patient leaflet, which was helped by one of our own patient partners, Tony Crenshaw, who's absolutely instrumental in helping us during our value stream. We looked at bringing a decision maker in RPIW2 to the front door, and again, significantly improving patient review from over 4 hours to 22 minutes, which I thought was the most significant of our changes. And then we also explored moving patients outside of SAU to the wards and access to acute theatres. And all of these changes were made and culminated in a visioning event, which took part in March 9, just prior to the start of our COVID pandemic lockdown. Next slide, please. So this work, the outcome of this work that was done, led to a large financial investment by the Trust, for which I'm very thankful, and for a cohort of 12 new emergency general surgeon consultants. I'm proud to say that I'm one of those in post, one of the 4 now, and was appointed in October 2020. We have 3 EGS surgeons, and we very recently welcomed a 4th, and we also have a professorial academic lead consultant in EGS. We would like to report out our early experience since our appointment. Next slide, please. So what we are trying to demonstrate here is that we have made changes to the patient referral pathway. So any patients requiring assessment or admission from primary care are now all being directly triaged by a consultant. The GP calls come through directly to us, where we are able to offer advice, or patients are directed to an appropriate assessment or triage pathway. Now, we have a number of pathways which exist depending on the patient pathology and the patient demographics. We have been able to collect our data, and we would like to share that with you now. Next slide, please. So what we have been able to show that in the 7 weeks of data that we are demonstrating here is that of all the referrals that we saw, over half of those patients, so 51% of patients, were assessed primarily in the ambulatory surgical care. So these patients that would normally have gone through to SAU came directly to us. 8% of patients were able to be given advice over the phone and did not require attendance to the hospital, and 10% were directed to other specialties. A third of the patients that were referred were seen on the SAU. Now, the significance of all of this and collectively is that we were able to reduce 70% of patients going to the SAU compared to the previous year. Next slide, please. We've also introduced some rapid access theatre lists. So what we have been able to show is that patients who would normally be admitted to hospital, in particular patients in this category, so gallbladder pathology made up about 40% of our admissions normally, yet we had no dedicated list for these patients to be operated on. So the alternative was for these patients to be managed conservatively or to be placed on the emergency list. And an average length of stay for a patient of this nature was about 4.5 days. Next slide, please. So since our appointment, we have been providing 3 sessions, so 3 half-day lists per week. And these lists include patients with gallstone disease, patients with symptomatic hernias, and proctology, which is any anorectal disease, which we can manage in a day case setting, and discussions with the David Beaver's day case unit and anaesthetist allowed this process to happen with an SOP in agreement. Next slide, please. So what we have been able to show is that the patients that would normally, and I think we need to establish these are the patients that would have come into hospital, but because we've been able to manage these patients in an ambulatory setting, we've been able to send them home and bring them back in. Even though COVID has been restrictive, we've been able to continue this for our gallstone patients. And so we looked at a total of 34 patients aged on average about 44, equal men and women ratio. Next slide, please. And from booking the patient to getting the patient into theatres was an average of 11 days. And this also I have to mention, includes the isolation period that these patients had to have during this time because of COVID, and some of these patients needed to be isolated for 2 weeks. So, but we were able, once the isolation period was reduced, to have some of these patients in theatre within 3 days. Of the 34 that we operated on, there were no complications and no readmissions, and only one requiring an overnight stay. Next slide, please. So just a bit of the finance side of things is that if we look at patients spending on a night in hospital, we're looking at about £260 per day, and in those small group of patients we were able to save over £8,500. We've also looked at our e-pool list, because this is where these patients would present and normally wait, and that number of hours that patients have to wait, by taking them off this list, means that that has also reduced. That may be an indirect link, but that's something that we will address and review. Next slide, please. So I realise I'm going over time, so I might just try to speed up, but just wanted to really focus at the patient experience that we're seeing, because, you know, of the changes that we hope that we've made, is that they have been coming back with very positive outcomes and really quite happy. And you can see from the experience, the questionnaires that we've been completing, that the patient's experience is certainly a positive one. Next slide, please. And again, patients feeling that the communication certainly was much improved. Thank you. Next slide. So moving forward, and plans for us really, and this is despite sort of isolation restrictions, we've really felt that we've been able to sort of assess patients and treat them in a timely way. What we do plan to do though is have more movement forward. We're delighted to have further consultant appointments, and we've had a further addition to the team, Mr. Roy, and so we look forward to working with him. And we're also linking in with Plix to look at our financial and costings. We continue to review our data, and what we're hoping to do is to continue to streamline patient referrals and look at the pathways. Our work has certainly expanded quite considerably, and whilst we've seen that our improvement work has gone into other wards and CSUs, it's become fairly apparent that there are multiple teams now working in parallel to improve every section of our patient journey. And there has been talk of our value stream evolving into a model line, which would be the first, I understand, within the trust. I don't profess to know all that a model line encompasses, but as a team, we look forward to sharing our experiences with you. We're planning our next RPIW in June to focus on diagnostics, and watch this space. Next slide, please. And really all I'd like to do is just to pass on a big thank you really to all the people that have been involved, and apologies for those that I may have missed off, but really it's been a tremendous team effort, and we're very, very thankful. Next slide, please. Thank you.
That's fantastic, and should congratulate you on joining the consultant team. That's brilliant, and great to see the impact of this work, and also the way in which the team is growing, which is really, really encouraging, isn't it? So thank you very much. I'm sure there'll be questions at the end. Oh, Richard did you want to just come in? I hadn't seen you. Yeah, good. It'd be good to bring you in at this point, I think.
Yeah, hi. Sorry, I was a little bit late getting on the link issue. I mean, just a comment really. I mean, obviously, fantastic work. Really, really proud of the team. But I think for the wider organisation, what this whole thing says to me is that we've got a team here who came into existence almost like born through the Leeds improvement method. You know, we had a problem, we threw the Leeds improvement method at it, worked very hard for 2 years, and out of that is we've now got this team. But what's really lovely is that the team have embraced the concept from day one, and it's like, again, to use it Leeds improvement phraseology, it's now sort of standard work to consider every problem with a Leeds improvement method and I think that's really powerful. So that would be my main comment really, but very proud of it.
Absolutely, Richard. I sort of fully agree with that, and I think the point that Nasira made about us being one of the the biggest surgical centre. I think there's got to be some, I'm sure, conversations happening with Royal College of Surgeons and others about this kind of approach, and hopefully we can see the surgical community seeing the benefit of an improvement method in the way that we've used this, which, as you say, I think with the next generation of surgeons coming through, we'll see more and more of that embedding, and it's great to be leading that work. So I think really, really good point. Emily, I can see you've popped up. Did you want to add anything?
Just a very short thank you, Julian, that there were some crucial people missing off that list of thank yous. So what Nasira's presentation doesn't necessarily bring across is that during COVID, 3 EGSs who have been joined by Mr. Roy, who's on the call, have delivered an absolutely essential service to keep our patients safe during COVID. We absolutely could not have got through the surge capacity we need to put in place without the innovations that they've really started from an absolute standing start in October. So thank you, Nasira, and the rest of the team. It's been amazing.
That's great. Yeah, really important point there, Emily. And I think we've seen that. I've seen that myself with some of the visits that you've kindly invited me to make to the team, to see just how well that's working, and great to see the response that we've had. Fantastic. Well, that's got us off to a great start, Nasira. So let's move on to you, John, with your 150-day report out on patient experience complaints.
Yeah, thank you very much, Julian, and it was great to hear your presentation, Nasira, and I would echo some of the thoughts. I mean, moving on to complaint management seems at the other end of the spectrum. Actually, nevertheless, it become the two are pretty synonymous with each other. You improve services, you actually help reduce complaints. So it really is probably does dovetail quite nicely. So thank you very much. It's a real pleasure to present our 150-day update on the complaints Leeds Improvement Programme report out, and delighted to present with the CSU teams who are present as well. The process for those who don't know, the process for managing complaints is complex and challenging, and it became apparent that the performance indicators that we monitor require particular focus, and specifically in regards to CSU and complaint team management of complaints. So utilising a collaborative approach using the Leeds Improvement methodology, including particularly understanding value and waste, we have been making great progress towards making improvements, in particular in regards to the quality and timeliness of our complaints, which are the two main drivers for this programme. Next slide, please. Can we have the next slide? Thank you very much. So the target progress report shows an improvement in the lead time from when the programme first commenced in September 20. And you see on the right-hand side the percentage change in green, which we would classify those as positive indicators. But there is a slight slippage from the previous report out, which we will aim to address. And there are actually reasons behind this, including when the programme started and the length of time taken to respond to complaints. So I'm not entirely surprised that we have seen a bit of a slippage, but nevertheless, it's something we need to be mindful of and address. Now, the lead time is an interesting concept in terms of it's about the hours experienced by a complainant in the whole process, from receipt of, or acknowledgement of the complaint in the organisation to the response being posted out. And that's a slight shift in terms of how we view response times, average response times internally. And it actually adds the notion, actually, the person who makes the complaint is actually the person that we need to try to focus on and help through this. We also are monitoring defects, which is on the bottom line, and these are the complaints that reopen. And actually, the complaints, not only the ones that we are open, but the ones that we actually have direct influence in the particular from the original response. So this might include areas that have been raised by the complainants but not addressed in the response, or a response might be incomplete from their perspective. So within this, we look at the total number of complaints reopened and the percentage that are reopened because of those particular reasons. And as you can see, the trust average is 45%, and our CSUs have achieved 0%. AMS have unfortunately got a score of 100%, but that is just one complaint that has reopened since the start of the programme, and where the complainant felt as though the response had not been adequately responded to. So again, we'll probably see that that again is something that provides interest to us. Next slide, please. Our newspaper report shows that the problems we identified in terms of timescales and expectation setting, and also coaching for the CSU staff involved in the programme, have all been achieved. And the coaching programme was great to be involved with. We had great buy-in from the CSUs, and we particularly see this as a really important way forward for the rest of the trust. And we have developed, we are in the process of developing a 2-year complaint training schedule for the trust, and we will be kick-starting that with a conference on the 10th of March, which we will be promoting soon, and provides an important context for the whole of the organisation through our learning and understanding through the programme. Next slide, please. If I can introduce you now to Julie Lofthouse from the AMS CSU to present their update. Thanks, Julie.
Hello, I'm Julie Lofthouse, leading us quality and safety in AMS. So what have we done so far? So what we're starting to do is look at the number of responses that are sent back when they've gone to external QA. And in January, we sent 6 for QA, and none of those have returned with any material changes. It might just be a little bit of grammar corrections. So we've had no defects in that, which is really encouraging. We've got our standard work description in place, and we have a flow chart that we've shared with staff and an escalation process. What we're looking at now is revisiting that. We do have 2 new deputy head of nursing, and Kate Smith's obviously standing in for us at the moment, and we're going to work with the general manager, Emily, looking at those and how we can support teams and achieve our targets. We have delivered, some staff have gone through the coaching classes, and that's been really useful for them. We're using PET team for assistance with really tricky issues, and we're working with the CNS teams as well to support patients. And we're trying to encourage staff to contact the complainants just to clarify concerns, because we can see that with some of the 20-day responses, we potentially could close those down. So what's the impact? We're starting to see a cultural shift now. Staff are really understanding the patient's points of view. We're starting to get leaders leading, looking at themes and how we can improve services. That empathy with the patients and carers is certainly coming through in the responses now. We're starting to discuss complaints at business meetings, which are led with the general manager. And we're also looking at duty candor letters and PALs to try and make sure we're writing those in the right way, and being empathetic with patients and carers. We're getting comments received in a timely way, and the responses are improving, which is reducing the bottleneck at the QA stage and rework. So where are we now? So in January, we managed to close 8 complaints, which is a bit lower than we achieved in December, but I think that reflects the pressures and Christmas and where the teams are. We are achieving a 48-hour turnaround for internal QA by our head of nursing. Unfortunately, we're still, we're continuing to see a theme around cancelled operations and clinics, which is due to COVID. And we're working with the specialities, consultants and CNSs to make sure those patients have got support during this challenging time. And thank you very much. So next slide, please.
Thanks, Julie. Celia isn't here to unfortunately be able to present. Celia Mackenzie from Children's CSU, so I'm presenting this on her behalf. So Celia wanted to say that they continue to focus on early contact with families, which is key to the quality of our responses. And Julie mentioned about contacting complainants when they receive the investigation. And I think for looking at the participants on the call today, I think this is a really important message to get out to the CSUs. Please do not be afraid of contacting people who have the cause to complain when you receive the complaint pack and before you start the complaint investigation. This is that we know that people are not always able to eloquently describe the things that they are concerned about, and having a phone conversation to elicit exactly what their concerns are can actually really help change the focus of the complaint. And Celia will recount a complaint fairly recently where it did not get taken forward because actually it was dealt with at the outset of that conversation. So please discuss that within your CSUs, and this is one of the key messages that we will be getting out in due course to all the teams. One of there certainly is a really good blossoming relationship between the complaint handlers and also the CSU teams who are involved in the project, including myself. And I feel closely aligned to all of the CSUs. We have great conversations, and I think actually it's been really good for staff morale for everybody concerned. Celia is also, they're also looking at further improvements, so we'll be doing this using the LIM methodology for the next focus, which is the quality of responses when received for internal QA. That's quality assurance, and she's also aspiring to further reduce the response times to complainants. Next slide, please.
Hello, my name's Bev Brown and I'm Head of Nursing for Emergency and Specialty Medicine. So as John and Julian have alluded to, this is our 150-day report out, which exceeds the usual 90 days. So rather than just saying what I normally say, I thought I'd just try and change it around a little bit. The ESM slide contains all the changes that we've made, but I thought a summary might be more helpful today to people. So at the beginning of this value stream, ESM were in a fairly good position considering the number of complaints that we receive. And we recognise that our improvements may not be as dramatic as some other CSUs. However, we were still really keen to be involved, as there's always room for continuous improvement to the service we deliver to our patients and their loved ones. So we saw this as an opportunity to link in with the heads of nursing, with the complaints team, to have those really good relationships, and the teams on the other wards as well, so that we can all learn from each other. The main improvements that I feel we've made in ESM was the creation and sharing of our standard work form, which I'd recommend to anybody, because you all think you know what happens when actually you don't. And in that standard work form, we've made it really clear about our timeframes and our responsibilities, so everyone knows what their role is in responding to complaints. We've also done the matron calling for single complaints, and that has been invaluable. There was a little bit of a myth that we couldn't contact complainants because patient relations did that. But actually, by speaking to families, you actually get a clear understanding of what their concerns are, what they want from the response. And again, we've just closed one down this week that we no longer need to respond to. But it's not just avoiding having to write a response, it's actually making that person feel listened to and valued, and that you've actually done something about what their concerns are. We have our weekly accountability meetings where we get a full picture of where our progress is, and also about what support our teams need to help them deliver what's expected of them. And then finally, the coaching. So the coaching sessions that the patient relations teams have put on, but also we do some one-to-one coaching with our colleagues. So when the author's written a complaint response, if we feel it needs a considerable amount of work, we will sit with that person and go through it with them to explain how we think it might be answered differently to make it more impactful for the complainant. So all of those things together have refocused ESM, I believe, on the importance of providing complainants with timely answers to their concerns, but more importantly, the benefits of sharing the learning from patient experiences, so that we can continue to work towards getting it right for every patient every time. And that's what this is about. Next slide, please.
Good afternoon, my name's Diane Armstrong. I'm one of the matrons in TRS. So just an update on where we are currently. We continue to have our weekly huddles on a Monday morning where the full team comes together and we discuss our current position. We discuss anyone who needs any further support or any tricky issues or any delays so that we can support each other and move forward with that. Similar to what Bev said, we're continuing to have that coaching in real time, so patient experience team and ourselves match up with other complaint responses to be able to support people who are more new to the process. We've recently taken on a new member of staff who's not done complaints before, so we're working with that member of staff to support them through the process. Our head of nursing, Donna Pearson, who can't be here today, is continuing to coach and support 3 of our business managers who are quite new to responding to complaints. And again, as Bev just alluded to, we're ringing our complainants as soon as we're having those complaints allocated to us. And that's really opening up a dialogue, not only to be able to address some of the concerns there and then, but to be able to give them some real qualitative feedback around some of our processes and patient experiences, so we can take some immediate actions to improve things whilst responding to the complaints at the same time. We've recently had a complaint, and whilst it remains open as a complaint, through those conversations and through those phone calls, it's actually, our response is going to be a meeting, but more around with the ward teams to learn from that experience that the patient and family had, as opposed to them wanting a written response to what they've raised within their letter. We continue to make efforts to improve our timeliness and our complaint responses, and we've seen a reduction in our open complaints since we've started this work. Our focus going forward is that we will continue with our weekly huddles. We found that a really valuable tool for the whole team. We will continue with our coaching of staff, and we're aiming to continue to improve our timeliness. We're hoping to achieve 100% compliance by the end of March. Thank you.
Next slide, please. Thank you very much. One of the things about the programme, I hadn't heard about that. Diane, if you could send me the details about how you changed that complaint, the management of the complaint, that is one of the fascinating things about the programme, and we're learning from it all the time, and we can really take some key messages from that. So thanks for that, Diane. On our next steps, we're going to be including 4 new CSUs in our next stage of the complaints programme. And for the existing CSUs, we will continue to report out for every 30 days. We'll liaise with the KPO team with regards to that to see whether that's still appropriate and whether we still want to, we still need to do that. We are going to be having less frequently accountability meetings, but I think one of the key points that Richard Baker alluded to before was about we've learnt the tools of LIM and feel confident in taking it forward into the next stage of the programme. I think that's really important for the CSUs involved, who can actually then monitor their own internal methodology, and we can do that as well from the corporate side of things as well. And this notion of shared learning with all the CSUs as well, about the complaint handler attending all CSU complaint rules, which we think should be set up across every CSU, having the standard work plans that we've talked about today, which actually sets out the tone and the processes within each CSU, and the ringing complainants at the outset of the complaint. And we've heard some really good examples today about that as well. And finally, when we think about data, in my mind, the LIM process has changed my notion about how we should report data as well. And so I'm just undertaking a review at the moment about how we do that as well, so we can actually report out with meaningful information to the rest of the organisation. So thank you very much for listening, and happy to take any questions.
Great. Thank you very much, John. That's great. And Julie, Bev, Diane, great to have you reporting out on your progress. Really good to see. So thank you. It's really encouraging, and well done on doing the 150 days, and looking forward, John, as you say, to rolling this out further. It's really making a difference. Let's open it up. I'm conscious we've gone slightly beyond one, but I'm keen to just give the opportunity for questions and comments to colleagues. So if we can bear with it for just a few more minutes, that would be great. So who'd like to come in? That's great. Tony.
Hello, everybody. Just a very brief comment about the centrality of the Leeds improvement method throughout this. I've been involved in both of these pieces of improvement work, both the AMS value stream and this work on patient complaints. The two are very, very closely related. I remember clearly having a conversation over the phone with Penny McSorley in September 2018, where she was in essence functioning as a complaint handler. But by the end of that conversation, I'd been recruited to be involved in the improvement work, which I've stuck with for two and a half years. And in that, I've seen the fantastic commitment of the staff of that value stream of the AMS CSU. It's just been fantastic, right up to the visioning event and the achievements that they made by incremental improvements. But then to hear the report from Nazira today of the way in which that has been sustained and carried forward is fantastic. And I also have to say that the support from people within the executive of the organisation has been central to that, because without that, there would not have been the inputs which, in terms of capital, if you want, for want of a better word, which there have been. So it's just fantastic to see. But that the importance of the complaint handler talking to the patient is central, because whilst it is important that healthcare workers enable patients to have a good experience, it is also very important that patients enable healthcare workers to do that.
Really good point. Really well said, Tony. Absolutely agree. Thank you very much. Tom.
Yeah, just very quickly, Julian. It's just great to see the Leeds improvement method in action. We talk a lot about this at the board, as you know, and hear a lot and see a lot of evidence of it at board, but it's great seeing projects like this and lots of colleagues involved as well. So a big well done to everybody involved. Really, really clear presentations as well. Thanks.
Yeah, thanks very much, Tom. And I know that everyone appreciates having board members join Report Out. It's really good to have the support and the perspectives that our non-executive directors bring to this work. And with you chairing the workforce committee as well, I think the importance of how we're trying to use this to promote the engagement and the Leeds way, it's all of a piece really. And it's but it's, as you say, good to see the very specific examples of how it's improved things. I did wonder actually, Nazira, just in terms of some of the points you were making about the team growing and the way in which, and Richard made the point about the way that the Leeds improvement methods are now kind of very much rooted in that way of working. Just what your thoughts are about the way that surgery will continue to develop and how improvement method, particularly obviously the Leeds improvement method, increasingly plays a part for doctors in training. So just any thoughts on that that broader issue?
Thanks, Jolene. Yeah, I think that's a really important point, and I think for me it's been a real sort of learning process on this journey, and I think understanding the lean tools and the methodology has helped me to have a better understanding of waste reduction, for example, and just to see how we can improve the patient pathways. So I think by having the opportunity and time to look at what, in somebody else's shoes, to be in that patient's shoes, and I think that's what we take away from this, and that's what we're trying to adopt as a unit. And amongst all of my colleagues, I'm very proud to say that we've all kind of embarked on the Lean for Leaders programme, and Mr. Roy, one of our new colleagues, we're introducing it to him. We also recently, Adam, one of my colleagues, put in an excellent bid to Health Education England for an extended surgical team. So this is reaching out to a much wider group, not only through the doctors, but also through the allied health professionals, the clinical practitioners, the junior doctors. And I think it's through this that we can adopt some of these teachings and get them more involved, really. You know, KPO have been phenomenal in giving us so much support, and they continue to do so. And I think we'll always be learning. And I think, as I sort of briefly mentioned at the end, model line, which I'm sort of feel like we're venturing towards, but don't totally understand completely, but look forward to learning more about. So yeah, and it's great to have this platform to share with others and to hear everybody else and everyone else's successes as well.
Brilliant. That's great. Thanks very much, Nazira. I just wondered if Helen or Jimmy just wanted to give us a quick sort of just a quick headline on model line, how that differs from a value stream, just to share that understanding.
Hi, Julian. It's Jimmy.
Hi, Jimmy.
Hi. I was politely waiting for Helen in case you wanted to step into that space.
You go for it, Jimmy.
So just checking, I heard the question, I was slightly between headphones. So just a bit of clarification around what model line looks like compared to our value streams. Is that
that's right. Yeah, just the term model line, it won't be as familiar to colleagues as value stream or RPIW.
Thank you. So essentially the value stream is looking at the patient pathway, and a model line is not dissimilar, but when we're into a model line territory, coming back from the manufacturing background, as you might imagine, it's looking at some of the interdependencies a little bit more. So for Nazira's example in AMS and the ambulatory surgical care unit, that's about how we connect their colleagues in radiology to make sure the scans they need to make decisions for their patients are available just in time, you know, in the right amount, the right time. It's making sure that there's a connection with, if they're deciding that the patient they're seeing needs some acute surgery, that there's a route for them to go down that flows and means that although the team on Nazira's unit there has done everything and mapped the patient process start to finish really well, there's not then a bottleneck in the next stage of the process.
Yeah.
So in essence, the model line is looking at those interdependencies and making sure that we've got parallel and complementary aligned improvement work in each of those spaces, which, as you can imagine, is then going to deliver, hopefully, even more impact in terms of benefit for our patients.
Great. Really well described, Jimmy. Thanks very much. And I think for us as a trust, it's the logical next stage of the journey, isn't it? Where you get those broader benefits by looking at things from a model line perspective. You start to see how all of the different value streams can join up and benefit from the removing the blockages and obstacles that might sit between them. So yeah, great. Okay, that's been really good. Thank you very much to everyone joining. Sorry we've taken a little bit longer than planned, but I'm sure you'll agree it was worth it. Thanks very much to both the report outs, really excellent. And please spread the word about report out. Grateful as ever to the fantastic KPO team for supporting this and all of the work we're doing. Next report out, Friday 12th of Feb, same time, same place. Look forward to seeing you all then. Take care. End of report out. Thank you.